This is where we started. We did a part one to this, and I'm going to very, very briefly kind of flip through a little bit of what we covered in the part one series, and then just jump on to our continue the program. Um, yeah, we talked about some of the technical advantages, and yeah, Rob already mentioned about the accuracy. It's off the wall, and it's just a milled technology to this PMMA material. It's the best it could possibly be. It's basically error free. Having preset arches is a great advantage on a technical side because the starting point is is wonderful. It doesn't mean that you don't tweak, and we're going to talk about that when we talk about tooth selection. So I'm really going to emphasize that aspect of things we get into the tooth selection process because I think it's very important for you to understand that a bit on the technical side, so that you, as a clinician, um, think a little bit more on how you want to communicate uh, that information to the laboratory. Very important. Industrial processed materials. As well as we try in the laboratory, if you're mixing, liquid and powder and you're mixing and whatever, there's always an element of inconsistency and whatever. Whereas these discs are industrially processed, so the consistency, the predictability of the physical properties is pretty well a given. So very little error could kind of, very little could go wrong in the way of processing. The uniform thickness aspect of it is kind of a side benefit to this process because the machine, you dial in how many millimeters you want your denture base to be, and it makes it uniformly that thickness. What's interesting about this as a clinician is the patients perceive this uniformity of thickness or thinness is a great clinical advantage in the sense that the dentures feel like they disappear in their mouth in his way they describe it. And I think the uniformity is one thing, but also it follows the tissue surface, the intaglio of the patient, so that it really does follow the contours, the actual contours of the patient's mouth, as opposed to us just arbitrarily filling in the palate with wax and literally not following the contours of the palate. So an interesting side benefit and very, very effective as far as patient comfort. Strength, it's off the wall. There's two different processing methods. We're going to spend a lot of time in this particular one, and Rob started with that's the Ivotion disc. And as mentioned, this is a solid disc, so you could imagine the strength of the material is as strong as it could be because it's totally monolithic. And we'll get into more detail of that as well. So some of the clinical advantages for you as a clinician, we could correct our errors and their artifacts, I should say, in impression taking. There's always little blebs, little scratches here and there, and little holes, little positives, little negatives. And this could be very easily corrected with this technology. Now, it may not seem like a big deal, but if it saves one sore spot adjustment or one moment of discomfort for the patient, it is a big deal. It's so beautifully done with this technology. You identify these little spots and hit a button and they just kind of blend in. It's a very useful tool. Another is the ability for you for relief to be added to areas of the cast, and this is somewhat according to your understanding of this particular patient, the tissue, the how you want to maybe add a little relief over the incisal papilla, maybe over the median palatine raphe, and fill in some of those real deep ditches into the rugae or whatever. What this does, it actually blocks these areas out so that the final restoration is relieved. Now, this isn't a lot of blockout. We're talking somewhat of microns here of blockout, but it's effective. It's really effective in reducing in the intensity of the insertion visit, meaning you don't have to work so hard to get these dentures to be inserted. And plus, there's definitely a relationship to the post-insertion number of visits as a result. So this is a great technical advantage of this process. Border extension, you're in control. You're in control of the individual borders. And these three things right here on the screen, I would think you as a clinician in some capacity would like to be involved. Now you could do this yourself by being part of the design process, or you use it as an opportunity to communicate with the laboratory, so that you and the laboratory technician makes a understanding on how you like things handled. And the graphics of this technology is so phenomenal that the communication is great, because you got to kind of, it's not just like, gee, just put that Figma jig over there. No, we could put this up on the screen. You could understand it. Gee, Rob, I like to have my extension such and such in this area and whatever. And you can make that communication very graphically, and therefore it's very, very understandable and communicable. I think is probably a good term for it. Um, I haven't post-stamped the denture in 5, 6 years at least. I never liked the process. It was a necessary process when you're having processing systems that have some element of distortion, most do. Some have a lot of distortion. But we're going to talk about these post-stamps, how they are a source of irritation and probably cause more harm than they do good. So we'll get back to that. But with this accuracy of this process, you don't have to post-stamp. Taking jaw records, and as a clinician, this is hard to do, and it's hard to do well. And because most of the time we're dealing with bases that are rather unstable, and whereas we could you can pretty much guarantee with our milled, even printed bases for the interim procedures, they're going to be extremely more accurate than what we've been dealing with our traditional denture bases. So your chances of getting an accurate jaw record is greatly enhanced. Um, Equilibration, there's software. We're going to touch on this equilibration aspect a bit, and it's a wonderful feature where we could preempt the occlusal equilibration aspect and prevent some very laborious procedures that are done typically as a clinical bike registration at the day of insertion, mounted in the laboratory, do equilibration. And so these clinical remounts are very time consuming, but boy, I tell you, the accuracy of this system is absolutely amazing. It could avoid a lot of that procedure. Um, Not to belittle this, because this is a huge benefit, and that's having a memory of the setup. Just discuss this with your patient, and you'll see in their eyes how important it is to them that that denture that they're wearing is recorded and could be duplicated, exactly duplicated, not just kind of make it look alike. No, but exactly duplicated, almost literally. It was like press of a button, and because this is locked into a memory with the software, and that's a great reassurance for the patient. And don't underestimate how important that is to them. Okay, all these wonderful clinical technical benefits. Why are we hesitating? It's human nature. Some of it is we haven't had this information in dental school, because most schools are just trying to figure this out and how to teach it and how to integrate it into their curriculum. So most chances are you haven't had any dental school education on this process. And maybe you don't know or haven't seen enough to see any real advantage to the process, even though we've just described many, but maybe you're not aware of it. There's probably some skepticism, and there should be. It's always healthy to be skeptical. And as far as long-term success, in other words, I don't want to do something that in 2 years my patients will be lined up in a hallway with holding their denture in their hand with the teeth falling out, or black stain on their dentures or whatever else. So if you're fearful of new materials or new processes, you should be, and kind of question those systems that are untested, I guess, and at least certainly not long-term tested. So maybe there's some fear of that for sure. Lab not experienced. Now you may have gone to your local laboratory and been a little disappointed that maybe they're not, up to speed on this particular process. I would say this: the laboratories certainly are gaining a foothold on this pretty rapidly. I've worked with Rob for many years, and some of the things I'm going to be showing you, especially with the tooth selection process and whatever, this technology does a lot. It does a lot, but it still requires the skill and talent of the technologists to really bring it home. And I hope to bring that point, very clear. So, working with Rob at Micro and his team, these are very talented individuals, and your chances of being more successful with an experienced team is obvious. Is obvious. So I can't overemphasize that. Maybe you tried it, and from anybody or everybody, and you had a bad experience. I hope you're attending this program, and I hope I could prevent you from having a bad experience. So hopefully there's some of this information would stop that from occurring. And maybe you hear mixed messages, somebody likes it, somebody hates it, somebody loves it. What's true, what's not true is really hard. But probably the number one, hesitation might be the fear of learning a new workflow, and none of us have time to sit back and really try to go back to dental school and learn these things. So there's certainly a genuine fear about learning a new workflow. I just want to make note of, this is our traditional workflow that we've done for 100 years, and it's worked well for us. But it's, with this new technology, we could think a little bit differently. And some of the unfortunate occurrences that have had in this development of this digital technology, we keep on thinking backwards sometimes, and you're thinking traditional, and how can we maintain traditional but integrate some digital into the process and things. And in a funny sort of way, it kind of held back the process instead of just thinking out of the box, and you kind of not that we can't learn from our traditional information that we've had, but sometimes it hampers us a little bit. And one of the earlier processes, we can still do this, is putting individual carded denture teeth into a milled base, and these are individually bonded and whatever. And I really don't recommend this particular procedure unless there's some reason that this would have to be done. But the technology is, again, this started this way to try to stay within the traditional understanding and whatever. But we got such better ways of doing some of these things. So it's time to think out of the box, and this goes for you too as a clinician. Don't be afraid to think just a little bit out of the box. Not that you got to learn things differently, but you got to just maybe think a little differently, and how to communicate with the laboratory, and think about your workflows and et cetera, and kind of go from there. So let's go with the workflows that we discussed last time. And very briefly, the traditional wax rim bite. In other words, you could do all the same procedures that you've always done, all the way up to the wax rim bite registration, and then have this scanned. In other words, the individual casts scanned and the bite registration scanned, and then start the design process from this point. Originally I thought, gee, maybe this is the better way for most of us to transition towards digital, is to use the wax rims. Now, I'm going to say something, no disrespect, because I'm included in this conversation. Wax rims are not easy to do. And the intent is good, that we do a wax rim, and the rim is going to be the prescription to the laboratory, right? In other words, how long the incisal length, and how far forward the teeth should go, the labial position, midline, occlusal plane, vertical dimension, things like that. The uncomfortable truth is, working with this amorphous wax, and you can't, and it's no one's fault. It's just you're looking at this glob of wax. It's sometimes hard to make really good decisions. And I'll tell you, I've done so many wax rim workflows with a lot of my colleagues, respected colleagues, and boy, I hate to say it, but we're off a lot more than we're on. So it's not a great way to get into the process. In other words, the communication of the wax rims to the laboratory is just okay. We could do better. And plus, you're not taking advantage of all the other digital aspects that you could clinically. So it's a possibility. If this is your comfort level and this is where you want to start in, it's okay. And maybe you're really good at doing wax rims. If you are, that's great, because then it serves as a good communication to the laboratory. But just saying. Taking impressions and bite in a patient's existing dentures, it's a great workflow. It's an excellent workflow, especially for this particular technology. Um, we went into detail about that, so I won't make too much repetition other than when we get into the tooth selection part, I'll kind of draw back to this a little bit, and I think you'll understand the value of this particular workflow. Immediate dentures this is an absolute slam dunk, as I mentioned last time, meaning that I almost I feel very strong about this in a sense because the patient benefit doing an immediate denture with this digital technology is so great that it makes me wonder if you're not using it, you're really not providing the patient with the best care. And it's kind of strong words, and I don't mean to come off pontificate that way, but son of a gun, you see the advantages of this technology to provide a patient, and I have greatest empathy for people who are going to lose their teeth. For a man, it's very psychologically damning, damning to his manhood and things. I don't get the psychology of a woman. It's maybe their femininity. I mean, it's an awful time for these people. And so you should be extremely empathetic. So the better you could transition a patient to dentures with an immediate denture, you just owe it to them. It's a terrible time for these people. Lastly, and this is what we're going to get into a little detail on, is our direct to try-in. And this is a great workflow. It differs from the other workflows, very distinctly different, because the other workflows have with them a reference matrix in the wax room. You got the wax rooms that's scanned in. It gives you the design technician a guide where to start. Impressions in a denture, you got the patient's existing dentures. It's a wonderful guide as a reference to start the placement of the teeth. Immediate dentures, the same thing. Even if the patient's got one tooth, it's amazing how much help that is in starting the process of designing where to put the teeth. Unfortunately, with the situation here, with the workflow we're going to describe, and this is where we start from scratch. Now, why do you want to start from scratch? I don't want to start from scratch anymore, personally. And if a patient has dentures, that's where I'm starting. I'm going to duplicate those dentures, and that's where I'm going to start. That probably is going to cover 80% at least of people who walk in your office have existing dentures. So why would I deny myself that opportunity to work with this particular workflow? Well, as I said, an occasion perhaps the patients come in, the dog got the dentures, they got no dentures, and you got to start from scratch. So this to me is my alternative workflow to not doing impressions in a duplicate of a patient's existing dentures. So let's talk about it. So we're starting from scratch. And what we're going to do is going to take impressions as you normally would. Again, nothing changes here. We'll talk a little bit about in the tips part of the section about of this workflow about different ways to take the impressions very briefly. But we take impressions. And we'll call them preliminary impressions, or if you're really fancy, you can make these literally into final impressions by the way you take the impression. It's your call. But typically they're going to be preliminary impressions. But they're traditional. And the only thing that's going to be a little a new learning here is going to be the Centric Tray and the UTS CAD. The Centric Tray is kind of a glorified mush bite because in order to get this into the software program, we have to have a arch relationship. Now we've had that with the impressions in a denture and immediate dentures. We got the bite and wax rims. We got the bite. So all those come with their inter-arch relationship. Where we're starting from scratch, we need a mush bite, and the Centric Tray is a very refined tool to help us take a jaw registration. The UTS CAD looks like a face post, not a face post, not really. And what it does give us some patient facial information. It attaches to the Centric Tray, and it's a very nice. This is a very nice This direct-to-try-in workflow is very nice workflow when you have to start from scratch. So we scan, do a laboratory scan, and we bring in the casts in a relationship according to the Centric Tray jaw record. So now we have our virtual mounting. We use the UTS values, the information I get from this little device, to help us select a occlusal plane and to provide us some information for that occlusal plane so that we could use that occlusal plane to help guide the positioning of rims. Well, this is how we started. We started with using, again, being encumbered with the traditional dentistry, we thought we had to make rims. So we start this process, get to this point, and then we'd have to go into a different design process to make and design rims. And thinking about this, why? Because it's just as much trouble. In fact, it's even more trouble, to be quite honest with you, to make a rim than it is to actually set teeth. And so why not skip this spot? And this is why the workflow is referred to as directed try-in. And it's a great workflow because it doesn't get encumbered with this traditional idea of having to have rims. I'd much rather have teeth to look at rather than look at an amorphous gob of resin. So we could design teeth. Again, using the occlusal plane as a guide to help position this setting of these teeth. And then we can make a try-in denture. And from there, we would go to a final denture. So that's the direct to try-in workflow. And the idea behind it, as I mentioned, is we ignore the rim stage. So, excuse me, that we could, instead of looking at those shiny rims, we could look at teeth. And the reason for why I'm kind of excited about this is because I think any of us, is going to be able to make, better judgment on the evaluation of these rims because they're shaped like teeth. I could see better. Patient could look at them better. The patients could function, talk with them better as you're testing, phonetics and things. So the rim stage is gone. It's gone. And so this direct to try-in, if we have to start from scratch, is a great way for that second appointment. I already got something to look at and something for the patient to look at and start making some discriminating judgment on the length of the teeth, the position of the teeth, the selection of the teeth, and et cetera. So it's a great workflow. A couple of tips real briefly. What's a good impression technique? Whatever works in your hands. Alginate is a fantastic material if you're good at it. It's not easy to take edentulous alginate impressions. We have the two-phase Accudent impression material, which makes it a little bit easier for sure. But quite honestly, alginate, fantastic material, tough to take impressions with. Again, different levels of experience. Some people are crackerjacks at it, and others struggle with it. Another material you may be interested in, I kind of like this now. This is the Virtual XD Putty impression material, and I use a regular body, regular set material. It gives me a little more working time. I love this. And what's nice about the putty is, again, I'm using a stock tray. So the putty's got a lot of body to it. And I got plenty of working time. It's got like 4 minutes of working time, like 2 minutes working time, I think, and 4 minutes to set. But it gives me a chance to go in and really, seat it properly, and it could, gets up into the sulcular areas very nicely. And gee, I take some pretty darn nice impressions with this material to start with. So I like this. It's really becoming a little bit more favorite than the alginate. But the problem with alginate, again, is fantastic, but if you miss it, you miss it. And you got to rip it out and you got to start from scratch and messy and et cetera, et cetera. This putty is, if you miss it, you add to it. So you don't have to trash the whole impression. You could always add to it because it's polyvinyl. So it'll add to itself, and also gives you the opportunity, if you so desire, to trim back some of the excess material and take a light body wash in the impression, and then it's your call. Is this could be a final impression? It's you to make that determination on how you handle these materials. So it's a couple of options. Could you do intraoral scanning? Of course you could. And I will dare say in, I don't know, a couple of years, maybe longer, maybe shorter, I think this will be what you will be doing as a routine. Intraoral scanning is becoming more popular. Um, I must admit I don't have a lot of experience, so I can't give you a lot of personal thoughts here, other than you scanning the maxillary arch is a whole lot easier than scanning the mandibular arch. And from in my hands, probably I could probably do pretty good routinely getting a good maxillary extended intraoral scan. On the lower arch, probably not so good. On the other hand, I just doing a case with a prosthodontic friend of mine, and she did a lower scan. It was was pretty darn good. I just couldn't believe she did such a good job taking a lower scan. So it's personal. Your talent, your ability to do these things is varied. I can only give you my thoughts. This is a Centric Tray. As I said, it's kind of a scaffold-like device. This is the Virtual XD regular set material. We just kind of mix it up into a doughy stage, and we apply it to the Centric Tray, place it in the patient's mouth. You could do some predetermined vertical dimension by putting a dot in the chin and the dot in the nose. If you got different devices to help you get vertical dimension, those are great. And then we take just a mush bite. Doesn't have to be pretty. I just need to have enough contacting surfaces here. And these are, I chose these because they're not pretty, but yet they're adequate for the purpose of doing this mush bite. And this will serve us to that'll be scanned, and then it'll be merged into the scans of the CAS. The UTS CAD will give us connects to the Centric Tray. It's placed back in the patient's mouth, and primarily it's adjusted to give us a value for the bipupillary line. Very important patient data to present to the computer. The computer will understand this number. In this case, here's like a +2, and the computer will understand that in this little slot for you to put that number in. It also has a sagittal or profile adjustment, and this is for the camper's plane. So it's the tragus of the ear to the widest part of the nose, the hollow of the nose, tragus hollow line that referred to as camper's plane. And we could take that record as well. And that's supposedly simulates the occlusal plane. That one is not of great value because you always have to tweak that a bit. But the bipupillary plane is very important to record. Again, we have a prescription, which we'll talk about later, and we have a place to put these particular values in. Just to let you know, Jay is going to be talking in a little bit. He's our marketing manager, and Jay's going to just mention to you we're in a process of finalizing this in instructions for use. I'm holding it up a little bit, unfortunately, making a few extra changes into it, but this will be available to all of you participants. And if you're really interested in these workflows, this gives a step-by-step, a whole lot more detailed information concerning that particular workflow, especially that workflow. Let's go to the prescription, and let's talk about manufacturing process. And so you have to select a manufacturing process. I quickly showed the mill. That's the program mill. It's an amazing instrumentation. Obviously, Micro is very well versed in that particular milling process, and it is very unique, and it's unique to the especially with the monolithic process we're going to be talking about. It's the only mill that can do the monolithic process, and it also provides a much facilitated technique for doing this, what I call the oversized process. And we'll get into a little more detail. So what is this monolithic process? What is this ivotion disc? Well, it's one disc, and as Rob mentioned, it's got teeth and tissue. So your one thought is, so it's one disc, 1 milling process, one denture from one disc. And first glance at it, you're going to say, oh, what's the big deal? So they glued tooth-colored, half of a tooth-colored disc and a half of a denture-based disc, and they, glued it together. I assure you, it's much more than that. First of all, the way these are put together, because they're not put together, they're processed together, meaning that when you look at the chemistry of this and you blow it up, there is no interface. This is a homogeneous, 100% solid piece of material. The different colors, but they are processed. So the physical chemistries of this are as a monolithic material. Now, what about the geometry? This sandwich between the pink and the white, there's a very unique, specifically detailed shell-like geometry that divides the two. And very briefly, what was done here, and it's just ingenious. I honestly, and I'm so happy Ivoclar did it, because that's my favorite people. But they're just geniuses who put this together. They examined thousands and thousands of dentures, and they tracked them. They tracked them with the help of all this digital technologies, and came up with a average. And I'm not an engineer, so it's impossible for me to really explain this in great detail. But these troughs that you see, this shell-like trough, again, these are very specifically designed so that you have total flexibility in the tooth selection, different arch forms and whatever. You could rotate teeth. You could, make changes and characterize teeth and things like that, and still stay within the pink and white. And I'm not saying like just close. I'm saying with precision, that indetectable. You would not be able to detect the difference between a conventionally processed denture, other types of milling type dentures, compared to these monolithic. It is precisely the gingival margin between teeth and base is indetectable, wild. And we could do small dentures, big dentures, and this ribbon, and this processing ribbon that is inside this disc virtually, is what gives the architecture, the gingival architecture to the teeth. And as I said, I still look at it and I do it and I work with it. I still can't quite believe it, but it does work. It just to show you, I hate to get too techie because I'm not techie, but this is something I put up on the screen, and you can see this this ribbon, and there's little handles here. You could adjust this ribbon and it basically changes the height or the length of the teeth. So this gives us some actually added flexibility compared to other techniques. So we could actually make some interesting changes, and to make you understand a little bit better, when I'm moving this ribbon, I'm actually moving the disc virtually. And by doing that, I'm repositioning the teeth into this pink and white location. And it just gives you a little better understanding of what's happening. And in looking at it in a profile, we could actually grab some different handles. We could kind of do some teeter-tottering here as well, making the lower length shorter and posterior length longer, and et cetera. And again, putting the overlay here of the disc, you kind of get a little better idea of what we're doing with playing games here with positioning the teeth within this white and pink component of the disc. So we do all this, and the beauty of it is the outcome, as I mentioned, it's indetectable. You can't tell, other than the fact that it was made. It's much stronger and has better physical properties, but you would never be able to see the aesthetic differences between the two. So in a nutshell, what we've done here, what they've done here, what the company has done, is they've taken conventional materials. This is your traditional materials we've used for eons, and basically optimized the physical properties. So when it comes to accuracy, it's as accurate as this material could be processed. It's it's 100%. The strength, the monolithic nature of this particular, it's as strong as this material can be. The fact that it has no interface is the fact that it has the physical properties of one piece of material. Uh, Not having an interface, there's no chance of discoloration or whatever, especially if it wasn't done properly. And then putting these things together, you might have some issues. Tremendous amount of design flexibility, as I mentioned, and certainly the proven materials. Just going to double check my time here. Getting a little close, and you have to be a little careful with that, and then predictable outcome. So having that these are proven materials, things you've worked with before, you could expect a certain very predictable outcome. Very few limitations. Size, sometimes extra large dentures or very steep retromolar pads might be a little issue. In that case, we have another manufacturing process. We refer to this as the oversized process. It's a great process as well, but it does do the teeth and the tissue separately. But the way this is a very patented process, and again in the PM7, it mills the teeth and the base not completely, but yet enough where you could polymerize them together. So once they're polymerized together, then they're put back into the mill to do a final mill. So when it comes out, that interface is virtually non-existent because it's so well taken care of with that final mill. So there's no cleanup, no extra material, or no chance of sloppiness of any sort. And it's an excellent material, especially for situations where we can't use the Ivotion disc. So let's look at tooth selection. I really did want to pop through this because I think it's just the whole story here, and I hate to have it at last here. But so what's tooth selection? We got a variety of teeth in our tooth portfolio. With the Ivotion disc, we have a very special tooth. It's called the Ivotion tooth. It is based on the Phonaris 2. So, and it's going to expand to other molds as well. But right now we have the Phonaris 2, and soon we'll have the Vivadent S DCL, which is going to be very exciting as well. So the facial appearance of the, the tooth, your expectations is exactly as it would be if we looked at the mold guide for the Phonaris 2. So if you're familiar with the Phonaris 2, great. If you're not, you'll find it to be a very simple, logical process. It's broken down. The anterior molds are broken down into small, medium, and large, and it's a very simple thing to understand. And then each of these categories of size is broken down into 3 soft and 3 bold designs, and then each of the soft, bold, and are subdivided into a youthful design, a universal or kind of middle of the road, and a mature, kind of an older type design to the teeth. So it's kind of an interesting system. I'm going to flip through it and show you how we could look at this in a more digital manner as opposed to just looking at teeth on a card, because now we got this technology. So I could look at these teeth, and these are the small molds. So I'm just going to flip through 3 soft and 3 bold of the small molds. And what's nice about this is you could become a student of the anatomy of these molds. What you're looking at here are the initial proposals that the technician will have at their disposal when they select this mold. This is what pops up on the screen. If I look at the universal series, now it's our soft universal, it changes to this. If we look at our more mature, you see the extra lines in the teeth and et cetera, look a little older. This is our mature series. If we jump to the bold, you see the tooth gets a little more squarish and a little bolder looking. And this is the universal series. and the mature. It changes, in its effect in each of these. And but you could look at this in a still version and really start to like understand these shapes. Now we can jump to the medium, and I'm just going to flick through these because you can see the three different soft medium molds. Obviously, they're a little bit larger, and the three different bold molds. And then jump to the large, and again, we can see the three soft series and the three bold series of the larger molds. And you can see how they set up. So let's go through the process of how you select teeth. And this is where I'm going to show you the workflow of taking impressions in the duplicate of the patient's denture and how valuable a workflow this is. What you're looking at here is the copy of a patient's denture, and which was used as an impression tray. So we took impressions and a bite. So this is, we're scanned, and what I did is I selected some teeth and I put them in this relationship, because this helps my vision of looking at the patient's existing teeth, and depending on my comments or the patient's comments about their existing teeth, they may want it to look like this or not. Maybe they want bigger teeth, smaller teeth. They're not kind of keep it the same. Maybe then you'll be surprised. Most people are saying kind of keep it in the ballpark of my original teeth. So let's take a look at this. Again, this is a teeth that I selected down here, and there was a small set, and it was a little smaller, obviously, than the patient's teeth. I picked on a large set, and obviously these are larger. And of course, guess what's next is the medium. Oh, that looks pretty good. So you're going to find most times the medium size teeth are going to be selected most often, and the small and the large usually are the exceptions. But if this is what I'm using as a guide, you see how this works as a reference. This is a reference matrix, and it gives me, the design person, a something to work off of. So this gives me. So I started here, and I'm in a ballpark. Another way of looking at it, flipping it upside down, you can see this matrix there, and you can see my canine is way forward of where the other canine is. And this is a small tooth, and this is a large tooth, and it's way on the other side of the canine. So you can tell the small and the large weren't good choices. Guess what? The medium was a good choice here. So another way of looking at it, and you flip around and do these things. So how about this shape then? Soft or bold? Well, let's take a look. This is a soft series here, and I don't think it matches the patient's teeth very well. It's another soft, a little bit better, but I think we could, yeah, I like that better. So as you become a student of the tooth mold anatomy, and it doesn't take much to do that, just by flipping these through a few times or referencing back to them, you can figure this out. And obviously the design technician is well aware of this, and they're going to be, if you give them the instructions to somewhat match the tooth or make it a little bit bigger or whatever, now you're giving them a reference to work from, and you could see what the magic they could do at this stage. Now we also are able to do morphing. So if this is our initial proposal, I could go around and tweak these teeth by changing their shapes and size and positions a little bit, but I could do some pretty neat things. So this is where we started, and this is kind of where I'm not great at this, and I kind of make it look a little bit more like their denture just by doing a little morphing procedure to the teeth. So absolutely invaluable. Now this is another case I'm just started, and this is a intraoral scan for an immediate denture. So these are patient's existing teeth. Same idea. This is a reference matrix. And again, I want to get in the ballpark, and I selected a tooth and size-wise, kind of in the ballpark. But now let's take this, and I could show different highlights. I kind of like the pink, a little bit better contrast here for me, so I stayed with that. And I'm doing another morphing here. Watch what's going on. I'm pulling the teeth a little here, a little there, and growing them a little bit. Watch this. Watch the watch the canine. So I just kind of morphed the mesial of that canine a little bit and just made it a little bit sharper. And so these are little tweaks. Same thing on that side. And so that's the initial proposal. And this is where I ended up. So yes, it's great to have an initial proposal, but having the talent of an experienced removable technician in particular, or just I shouldn't say that, of a good technician or someone who knows the software inside and out. Obviously, Rob is that person and his team, and so you start here and you end up here by understanding the how to use these tools. So, and believe me, it only takes me a minute. It's just not that it's just knowing your tools and to play with a little bit, and you can make a really neat improvement. I mentioned about immediate dentures. Do you realize how nice this is for this patient? That I'm going to be positioning these teeth as close to where they were, and this patient really wants these teeth to look the same way. And I thought, what a wonderful service that can be for the patient. Very quickly, because now we're running out of time, we have posterior denture teeth. We've got to make a selection, and I flipped kind of quick through that. It's the orthotip is our, we've got an orthotip option, and we have an ortholingual option. The orthotip option is our semi-anatomic or 20-degree tooth. Beautiful tooth, and it's a tooth that intercuspates. It's a semi-anatomic, so it has some degree of intercuspation, and it lines up beautifully. Beautiful tooth. However, as a semi-anatomic tooth, the buccal overlap is somewhat more like a natural teeth, and that's why I call it anatomic. It's kind of like patterned after natural teeth. And this, they're beautiful, and I like the occlusion with the orthotip, a very natural tooth type of occlusion. But I feel that some patients, in particular older patients, they tend to get into cheek biting and things with this type of occlusion, and it's a little more complex to understand. Because let's go through an excursion, and we're marking our lateral excursions and protrusive excursion, and son of a gun, you're going to see a lot of contacting surfaces on the upper and the lower. This is typical of an anatomic occlusion because it's complicated and it's a lot of contacting surfaces. In contrast, let's look at the ortholingual. These are some old slides. I was very involved with the with lingualized occlusion. My mentor Howard Payne was my influence, and so I came into the company very hopped up about lingualized occlusion. Worked with Lee Culp, and we patented the lingualized occlusion for Aviclar Vivident. So this ortholingual is our particular patent. How I wish we had the digital technology back then to even make it better, which we're going to show in a minute. But typically, we have to do a remount record. With the traditional dentistry for lingualized occlusion, we have to reestablish centric contacts. We put the teeth in excursions. If there's any buccal cusp interferences, we try to avoid that by setting the buccal cusp in an elevated position. Unfortunately, it gives a little funky look to it because the posterior teeth it doesn't look as pretty as a semi-anatomic occlusion. So that's a good and the bad of the traditional lingualized occlusion. This is the Ivosian Fenaris 2 ortholingual. Fantastic. Look at this. You wouldn't know this is lingualized occlusion until you flip it up and you see the space between the buccals of the teeth. And let's put this to the test of excursion. I did no equilibration. This is how these teeth are set. And our protrusion, and let's take a look at the contacts. So you're seeing a classic lingualized occlusion. Only palatal cusps are making contact. Freedom and excursion on the buccal cusp side, and on the mandibular arch, basically central fossa with some guiding surfaces, working and balancing. And this is unequilibrated. So it's a beautiful occlusion, a little easier to handle, easier clinically for me to do any kind of adjustment to it, very simple to understand. And now with this technology, we improved what Lee and I did. This is an improvement of that, and using this digital technology to really bring us forward. Very briefly, these are some communication tools. I won't even go into detail. The denture gauge and a papillometer. These are options to use to get patient data. Our prescription form would be something that you could download. Jay will make a quick mention of this as we go through it, but it's a wonderful form. It's got a nice evaluation on the second page of the form that could be used for anything, for immediate dentures, for impressions in a denture, and et cetera. So a very nice prescription form, very proud of that. Clinical try-in, again, where the greatest challenge is going to be to get away from the wax type try-in, realizing that each of these workflows will tend to end up into a try-in. Here's we could look at our fit. If it fits, it fits, because the accuracy of this process gives you pinpoint evaluation of it. If it doesn't fit at the try-in stage, you have to take another impression. Then we look at the evaluation of it, and we go through all the different parameters of evaluation. And then we look at the bite, and sometimes we have to take a new bite, and sometimes we have to take impressions and a bite at try-in, or sometimes you do nothing. So it all depends. But this is your classical clinical try-in with this material. A couple of tips. If you have to take an impression, obviously it's going to be, you want to have the teeth together while you're doing the impression. You could add, if you missed a border, you could just only add a border. Here, I missed a retromolar pad, and I just added the retromolar pad. And then a little comment about vertical dimension. It's somewhat incumbent upon you to make a choice clinically, looking at the incisal length. And if your choice is, well, in this case here, his upper teeth look great, incisal length, this is a try-in, except I can't see his lower teeth. So I want to lengthen his lower teeth, but you know what that means? It means that I communicate to the laboratory that I want to lengthen the mandibular teeth by X number of millimeters, but that means to them that they will then increase the vertical dimension. But that's a lot of information to try to get. But we could knock down those posterior teeth and take a nice bite registration at the vertical that I want this to be established at. Or you could mark the teeth with magic markers, or you could grind the teeth. You could do anything you want to do that would allow you to communicate best to the laboratory for what you want to accomplish. So it's and then the nice part here about these resin try-in dentures, that patients could take them home, and in the their familiar bathroom mirror, that they can make some choices at that stage. Insertion, that's the bottom line. And the insertion appointment is where you figure out if I did a good job or I didn't do a good job. I could say it's fair to say that I've reduced my post-insertion time, my insertion visit time, at least by 75%. Sometimes I do nothing other than share joy with the patient. And so the intensity of the insertion, in other words, the amount of adjustment I got to do, it's very minimal and hopefully nothing. And I've never been able to do that in traditional dentistry. Some of the articles written show that this indeed is true, that the insertion with these mill denture base is going to be less than traditional dentistry. Kind of interesting too is this article identified the common sore spots, and on the mandibular arch, it was due to overextension of the lingual flange and the buccal shelf areas. And this is a throwback to you getting involved in the outlining of the cast. I don't engage. I select not to overly engage these severe undercuts on the lingual. And in the buccal shelf area, I make an assumption personally that I'm always overextended, because you tend to always, with your materials, push that area. So I tend to try to underextend this a little bit, and it saves me, I think, from having sore spots. It was kind of neat to see this article kind of back up those two areas as being an initial problem. Highest frequency of maxillary adjustments were posterior palatal seal. So don't do a past palatal seal. You're going to save yourself potential adjustments. The second highest frequencies of both arches were the gentle, the softer, thinner tissues around the ridge crests. And as I mentioned, with this relief, that I'd love to see you participate in it or discuss it with the laboratory. You will save sore spots, patient discomfort, frustration, post-insertion visits, and et cetera. So I've gone through that a little quickly because I know we're getting a little short on time, but I promise you, once you taste the Kool-Aid, you ain't going back. There's just no turning back. There's just too much advantage to the patient and to you as a clinician. I think you will enjoy removable prosthodontics to a much higher level. These are the clinical instructions. We promise to make them available to you. Rob will be and Micro will be giving you emails on after the program. Give me a week or two to get this completed, and we'll certainly get that information out to you, to everybody. Again, it's a team effort. I'm proud as a clinician. I'm proud to represent Ivoclar Vivadent. I love the innovation. I think this is the state of the art and innovation on removable digital at this point. Is and for all the reasons I said, which I won't repeat. And you need a experienced, talented laboratory team. And I have my every confidence in Rob, my every confidence in Rob, and every confidence that he selected the absolute best team. So remember, in closing, that communication is everything. So if you're not a good communicator, think of these workflows, think of the ways how these reference matrices could work for you, and let that be your conversation piece with the laboratory. Use that as your reference. And so this whole system kind of forces you to look, be more observant, make better decisions on what you have to work with. And the copy of a patient's existing denture, as I said, is my favorite. Thank you very much for everybody who was able to hang on, and I hope you walk away with a little more information, maybe a little more appreciation of the process, and maybe a little reassurance that clinically this is very doable. And it's not an effort, it's the opposite. It's going to save a tremendous effort on your part. And I think you'll so much better enjoy removable. So I will back out. And I believe, Jay, I will let you take over. Do you need me to stop my share my screen or anything?
Nope, you're okay.
Okay.
Great job as always, Dr. Frank. I know we are a little bit over. We do have some questions, so if we can get to them maybe in the next few minutes, that would be great. So I'll just go through at least a few of them, and whatever we can't answer, then we can send out later. So one question, I think it is efficient to make a digital model directly from the impression body without using a plaster model. Is there a problem not to make a plaster model?
No, there's no need for it. If you're in other words, why would you do models? Um, because your everything is going to, unless you needed it. I mean, you could do models and do it that way, but the whole purpose of this is pretty much. Let's say you do any of these workflows. Let me backtrack a bit. You do the wax rim workflow. Obviously, you're working with models because you've done the traditional workflow up to that particular point, which means you poured your impressions and made models. And then for that particular workflow, you will scan the individual models and put it into the wax rim bite registration. Then you scan the outside of it. So it all blends together. So you're able to get a virtual mounting. But for the other workflows, really, there's no need to do anything other than everything's virtual, and so no real need to fabricate um, um, models, even digitally.
Great. Another question, by using PVS putty impression material, won't the soft tissue be too compressed in some area, causing sore spots?
It's a good question, and I think that's the way you want to think of it. If I took a simple putty impression, I would consider that by itself a preliminary impression. But if I took that same impression and I cut back the extra material and maybe relieved a little bit around the anterior papilla and median raphe, and then did a light body wash, I would probably consider that a final impression. And being in occlusion is a little different. We kind of call that technique of impression taking a closed mouth functional impression, and we've done this in traditional dentistry forever. And But in this case, it's just a natural way of being able to take these impressions. And it does put the tissue in a more functional form, as opposed to, let's say, if I did a pure alginate impression, I'd probably capture the tissue more in its anatomical form. And there's theories on which is better, which is worse. I could only tell you, I think impressioning material tissue in a more functional form provides a more realistic fit to the denture, to the tissue. I think if I capture tissues only in their anatomic form and you insert dentures, getting more theoretical than practical here, but the idea is that you'll probably get more compression then into the final dentures when they're inserted, as opposed to dentures that are fabricated to functional impressions. They tend to more functionally seat. All theory. On the other hand, it certainly works well. So, but if I was doing the impressions just with putty, I'd be a little concerned that maybe I'm pushing things unevenly. But then if I back that up with a light body wash, I'm pretty comfortable.
Okay. So we are 15 minutes over. Maybe we can answer these other questions and send the answers out to you separately. If that works, Medina, just so we're not going too over.
Yeah, I apologize for running over.
It's all great information, Dr. Frank.
No, everyone stayed on, so it's great.
Wow.
Thank you so much, Dr. Frank and Robert Cryer. I think it was great. I think if anyone needs these answers please email me or Jay. My email is masefi@microdental.com. And Jay, can you go ahead and say your email?
Mine is jay.cranston, CRANSTON, @ivaclar.Vivident.
Yes. Thank you so much, everybody. This was a great webinar, and we appreciate all your help. And Jay and Dr. Frank and Robert, I don't know if you want to say one last thing, Robert?
Just thank you again, Frank and Jay and Ivaclar Vivident for helping co-sponsor this webinar. And please, don't hesitate to contact me at Microdental if you have any questions regarding digital workflows, whether it be complete dentures, partial dentures, any of the digital products that we offer. Please reach out to me via email or 800 number at Microdental California.